Yeah, again, after that interesting concept, again, as Antonio Colombo always does very interesting things, a lot of questions are coming up on this new concept which he proposed. We'll have more discussion later, but we have to move on. Now, the next symposium is innovative solutions to treat diabetic patients. In India, we do see a lot of diffuse disease, what he proposed, and also we have diabetes increasing. So I think this session will be more relevant. I hope other panelists, Dr. Ravikant, Patil, Subhanan, Rishi, Sethi, and Sangat Velu also are there. And with this brief words of introduction, I first hand over it to Dr. Colombo to introduce the session objective and his opening remarks. Then we go on to his talk. Dr. Antonio Colombo.
Okay, thank you again for having me. I see very good friends, Mary Claude, Luca, Testa, hello. And you know, diabetic disease, diabetic atherosclerotic disease is a severe issue, not only in Western country, but in Asia, in India. And we know how poor PCI has been successful in this group of patients. We cannot scratch the result of freedom trial, where the endpoint of death is on our head. Even if Syntax trial did not show diabetes as a marker, I still am attached to the freedom trial result. So we need to do something if we want to be successful with PCI in diabetic patients. And I'm glad about this effort. We will, in this symposium, we still don't have data, but we have a lot of activities going on, and all the participants will present what we are seriously doing to handle this problem. This problem is not going to be easy, because diabetes is a very complicated disease, you know better than me. So let me first go ahead and do the introduction about a device, a proposal, a study, and then we go more deeper with the other speaker. I need to share my screen, and just let me a moment to open my presentation. Okay, so I will go over this unique stent design to treat diabetic patients, and then tell you what we did and what we are doing to test this technology. So let me summarize briefly this technology. This is the scheme of a stent. And first of all, there is abdominal coating. This is nothing new. We have many stents with abdominal coating. Makes sense because the drug is given to the wall. The unique feature of this device is coating on the stent as well as exposed part of the balloon. So the coating is not only on the struts, but with sirolimus, of course, but is also on the balloon. So the whole idea is to have a more homogeneous drug delivery on the vessel wall. In addition, because the balloon is coated, you have 0.5 millimeter of coating outside the stent in the proximal and distal margin of the balloon. And this fact should address an occasional problem of the edge restenosis, which is not common, but it can occur. And we all know that in every stent delivery system, the balloon protrudes more proximally and distally. This coating is done with this unique biodegradable film, which is basically a very thin layer that covers the whole delivery system. So this is the regular stent delivery balloon, nothing strange. The tip length is standard, the crossing profile is very low, the maximum size a little bit less than 1 millimeter, 0.98. And as I said, the unique aspect is that the protruding part of the balloon, which is present in every stent delivery system, is coated with sirolimus. The stent is a modern stent, and for modern I mean hybrid cell design, which is basically open cells in the center and closed cells at the margins in order to avoid longitudinal deformation. So this is a very important aspect. The strut thickness is 73. There is a link between the struts, which is 60, and the strut width is not a lot, is 120. So these are what I call second or third generation stent, thin struts, not ultra thin, but 73 microns is the thin struts. The stent is a modern stent, which means that we have 3 design, one for a small vessel, one for standard vessel, and one for big vessels. So we can really go to stent the left main because the coverage is well guaranteed, and there is not a lot of metal when you go to small vessels. So this is an additional feature. The drug release is very effective, up to 45 days. The maximum delivery is at from 7 days to 48 days. So it's really a good delivery profile, optimal for mitigate smooth cell muscular proliferation. This is the in vitro release with different sizes of the balloon and of the stent. As you see, it's very similar with different sizes of devices. The data are several. I'm not going to go into details, but just go into some summary. The first study was done in India by Samir Dani. First he patient is a feasibility study. Then we have a single-arm multicentric registry, and then another big registry that will be presented by Luca, Testa, on everyday patients. You see the two first studies have been closed, the third one is still ongoing. Then there is a small but very interesting study that I will describe into more details later, which is a randomized study to evaluate tissue growth inside the stent. And then there is a real big study, the Diabetes Mellitus global study, 3,000 patients. And then there is a acute coronary syndrome. So there is a lot of meat on the table, and this device is going to be really tested at the very deep. This is some summary data of the study on the 40 patients. This is not only for diabetics, but almost half, 42% of these patients were diabetic. It is a single center feasibility with angiographic follow-up at 6 months in 39 patients. So almost everybody went to angiographic follow-up. And this is the value of angiographic follow-up of 0.17 in segment and 0.24 in segment, in stent. And don't forget that 42% have diabetes. The standard deviations are 0.29 and 0.30. So there is a certain spread, but you know, even at the worst, which is the worst standard deviation, we go to 45 of late loss, which is really not bad, considering that 42% were restenotic. This is a post-market registry of 2,000, 5,000 patients, I think done by Dr. Samir Dani. And these are the results at 1 year in diabetics and non-diabetics. Diabetics is in blue, non-diabetic is in pink. And you see that the columns are quite similar. There is the diabetics a little bit higher, but really not so bad. Cardiac death is 1.4, 0.8, TLR 1.9, 1.1. So maybe we are going into the right direction. Luca Testa will present his data, so I skip on this. And I want to devote a little bit of time on this randomized trial of Abluminus death versus everolimus to address intimal proliferation in diabetic patients. This study is conceived by me and Azim Latib. We started the study while we were both in San Raffaele, and the study is continuing. Is a multi-center, single-blinded, almost finished, almost, because we still need another 10, 15 patients, but nothing wrong to tell you the design. Is a 2-to-1 randomized to Abluminus versus everolimus, and the primary endpoint is in-stent neointimal volume at 9 months follow-up measured by OCT in the two groups of patients. These are some examples. These are just anecdotal examples. Please don't take these examples as a proof that something works or something doesn't work. But it's nice, at least you see that we are telling that we are doing the follow-up. This is the patient treated with Abluminus. Maybe is a nice result, and that's the reason why I'm presenting to you. But you really see a very favorable endothelization with a lumen area of 7.7 and the stent area of 9.2. So far, I'm pleased to see at least one good result. This is another good result with post-stenting follow-up at 8 months with very favorable endothelization and really very contained hyperplasia. This is a more severe hyperplasia, so sometimes things don't go the way you like. I believe whatever result we will do, we will not resolve the problem, but we hope to mitigate the problem. This is an example where the hyperplasia was more pronounced. The lumen area is 3.8, so you have a more severe late loss. But we have to see what the final number will tell us. And then we go to the ability. I think Marie-Claude will go this with more details. Is 3,000 patients with very limited exclusion criteria, randomized versus science, very provocative study, a very courageous study, because it's the first study that not only wants to demonstrate non-inferiority, but wants to demonstrate also possible superiority. It's a worldwide study, Europe, Latin America, Australia, is powered for non-inferiority and sequential superiority. So it's really a tremendous power of the company, the tremendous courage more than power of this company supporting such an important study. So to conclude, I will say that the Ability Global Diabetic may set a new standard regarding PCI in diabetic patients. And of course, there are many other approaches, drug-coated balloon alone, as we discussed in the previous study, but to have a dedicated stent which is more effective in diabetic patients will be a real step forward for all of us. Thank you for your attention. Can you hear?
Yeah, thank you, Dr. Colombo, for covering that. And they have covered some of the aspects of other talks coming up. And we'll have
So thank you. First of all, good afternoon, everybody, dear colleagues and friends there in India. So it's my pleasure, of course, to be part of this program. And as you know already, I'm pretty much involved in this evolution of this technology. I'm pleased to share with you some information and some experience that I've done in the last few years. So it's always also a pleasure to speak after Dr. Antonio Colombo, that actually introduced some of the concepts that I would like to stress during this short presentation. But anyway, everything actually started in terms of clinical program from the Enable e-registry. And as you know, that it has been a trial, a registry aimed at evaluating the safety and efficacy of the Luminous Test Plus in all comers population with minimal exclusion criteria. So the idea, the concept of targeting diabetes was not there since the very beginning of the program. But the point is that after some observation, 2,500 patients have been enrolled, and among them, more than 800 were diabetic. So the thing is that according to the data, the preliminary results, and what has been already published, by the way, they observe that the rate of MACE, but as well as all the possible clinical endpoints, was actually very promising, regardless the presence or not of diabetes. So actually that was the beginning of the idea, the beginning of all the program that we are discussing nowadays. The results of the Abluminous were actually consistent in patients with or without diabetes. And then actually that was the idea, to start a larger registry, not just in Asia or in India, but everywhere. It's a global registry. And I'm pleased to be the PI of this. And this is the dedicated registry. That is the drug-eluting stent for diabetic patients in coronary artery disease treatment. Again, this time we decided to have minimal exclusion criteria in order to have the largest availability of patients and experiences worldwide. The primary endpoint is a kind of a more modern endpoint, such as the target lesion failure, a composite of cardiac death, target vessel MI, and clinically indicated target lesion revascularization within 12 months, and a full list of secondary endpoint. I will not go through all this list. The situation is, as you can see here, up to date, we have 983 patients enrolled, but actually we are targeting 5,000 patients. And then, as Antonio Colombo already introduced, from the same idea, the ability randomized controlled trial has been actually ideated by Antonio and my friend Azim Latib, which is in the United States at the moment. This is an investigator-initiated pilot study with a completely different objective, because the objective was to compare the angiographic and clinical performance of the Luminous Test Plus versus the everolimus family in patients with diabetes. And the primary endpoint is an OCT endpoint, meaning that it is the instant neointimal volume and 9-month follow-up, measured with OCT, followed with PCI with Luminous Test Plus, compared with the instant neointimal volume following PCI with everolimus eluting stent. And again, another full list of secondary endpoints. This is the situation. And as Antonio said before, we need some more patients, but we are very close to the end of this trial. So I'm pleased to show you some of the imaging that we have taken from the follow-up of this patient. This is just case number 1. I'm talking about a gentleman with 53 years old, with type 2 diabetes, hypertensive, dyslipidemic, and a family history of coronary artery disease. In 2018, he actually had F1 angina with a positive ECG stress test. The echocardiogram was actually normal, with a normal ejection fraction. That's the angio. Metadistal RCA, some critical stenosis, actually. I hope that you can see clearly. I hope so. And as this is the left system, well, besides the presence of a fistula, which is honestly not important for us, there is a lesion in the middle AD, a lesion in the first diagonal, and a lesion in LCX. This is a typical aspect of diabetic patients with a diffuse disease. So what we did PCI to the LAD in 2018, and actually we put a 3.28 Abluminous Test Plus, post-dilated with a 3.0 non-compliant balloon, and then we did the plain old balloon angioplasty to the first diagonal. And that's the results. Pretty acceptable, I would say, in both lesions. And then we staged the treatment to the RCA that has been done two months after. And then we put another Abluminous 2.5 by 18 and Abluminous 3.0 by 26. But index procedure was the first one. And then, of course, the patient has been called back in the hospital for the planned follow-up, angiographic follow-up, and OCT. Patient was absolutely fine. That's the result after several months. As you can see, the angiographic aspect is pretty good. And that's the OCT. So I don't want to show you the entire run because it will take a long time. But as you can see, there is a lot of disease. The stent looks very good. There is some neo-intimal aplasia. The strat coverage looks perfect, honestly. And there is no edge dissection, and it's coming in a few seconds, at least for the distal part, but also, as you will see in a moment, there's no edge dissection, but full coverage and the proximal edge. So this is just one example at the distal edge. As you can see, there is full coverage and there's just the minimal neointimal hyperplasia. That's the MLA that we measured at the proximal part, very close to the proximal edge, and you see the MLA is 4.5 millimeters squared. But these are some other numbers that are actually useful for the trial. The strut coverage is 100%. The neointimal area at the narrowest segment is 1.9, and max neointimal thickness is 0.6. Again, MLA was 4.5 millimeters squared. Case number 2. A 67-year-old gentleman, type 2 diabetes, hypertensive, premium smoker, and dyslipidemia. A long history of coronary artery disease, and well, as you can see, starting in 2003 with an intralateral acute myocardial infarction, some PCI with a bare metal stent in 2003, and then again 2009, 2014, and 2018, patients has been hospitalized for unstable angina and then referred for new coronary angio. As you can see, there is patent RCA, very good result, and LCX was very good, and there is tight stenosis in the obtuse marginal. The LAD looks okay, but also there is a 90% stenosis into the intermediate branch. So the patient has been scheduled for PCI to the intermediate branch, and we put a 3/16 abluminous Des plus, actually preceded by a pre-dilatation. The final result, I hope that you can see. Oh, it's not running. Okay, that's the run. Very good result. And then, of course, we did a planned angio follow-up with the OCT. As you can see here, angiographically speaking, there's nothing relevant. It looks pretty good. But this is the run that I want to show you. And I will skip the first part. Let's see if we can do okay. So there is a lot of disease. Distal edge looks pretty good. There's a minimal neointimal hyperplasia. Again, it looks like there is 100% strut coverage. The stent looks pretty good and very widely patent. Proximal part and proximal edge looks very good as well. These are some numbers. This is something that we always took for the trial. And the MLA was 3.97 millimeters square. Again, strut coverage 100%. And the max neointimal thickness was 0.18, which is very good number. Case number 3. A lady, 60 years old, type 2 diabetes again, hypertension, dyslipidemia, and overweight. Clinical history started in 2004 with effort angina and triple CABG. In 2012, another episode of unstable angina with a PCI with a drug-eluting stent distal RCA. 2018, again, a non-ST elevation myocardial infarction. That's the coronary angio. As you can see, the left coronary artery looks actually okay. There is a critical stenosis in the RCA, and just to mention that the graft going to the RCA was actually closed. So this is the saphenous vein graft or D1. This is the right mammary artery and the left mammary artery. They are patent. So, of course, patients has been enrolled and treated for the stenosis in the RCA. In this case, this is a randomized trial. We did an Exaion spine implantation 3/38. We actually post-dilated with a non-compliant balloon 3/25. That's the final result at the index procedure, which is pretty good. That's the planned follow-up angio and OCT for this patient, for this lady. And that's, again, the run of the OCT. The distal edge was pretty good. It's also pretty good throughout the length of this very long stent. I go directly to the distal edge. Distal edge, as you can see, looks pretty good. And again, these are some numbers I want to show you. The MLA was 5.0. This is very good, big artery. Max neointimal thickness 0.25 and strut coverage 100%. So, in other words, these are my take-home messages. The preliminary clinical data concerning the abluminous technology showed promising in both the general and diabetic population. And the preliminary data from the OCT images show that at least comparable results with everolimus eluting stents, which are honestly some of the best in class nowadays. Indeed, there is a strong rationale to further investigate the potential of this new technology in the field of diabetic coronary artery disease. And this is a very good way, I believe, to introduce what Marie-Claude Morice is about to talk, because the future is waiting for the results of the Ability Global, which will probably, as Antonio said, set a new standard for the treatment of diabetic patients. At least we hope so. Thanks for your attention.
Thank you, Luca, for the interesting talk and very encouraging endotheliation results of the newer stent. We will have more discussion. Some of them, some have raised some questions that you have had endotheliation done within 30 days. Very good, but we will have more discussion on it after Professor Marie-Claude Morice's talk. I don't know whether Madam remembers, she has trained a lot of students like from India, and we were together in the Spirit Woman trial. We had quite good experiences with Madam, and we are part of it, and we are very happy to have you here in this TCT India meeting, Madam. And we will hear more from her on this Ability Diabetes Global Program, which Antonio briefly introduced. This is the largest randomized controlled trial to treat diabetic patients as of now. So let us hear more from Dr. Marie-Claude Morice, who is the principal investigator for this. And in the end, we'll have discussion on all the questions which have come up and some of the panelist questions. Over to you, Dr. Marie-Claude. Thank you.
Thank you, Dr. Kukuma, for the nice introduction. Very proud to be part of this symposium concerning the Ability Diabetes Global Trial and device, and thank to Concept for organizing that. As I was saying, I'm extremely happy to be at TCT India, as part of my heart is in India due to the many fellows that I had the pleasure to train when they were young, and now I see their wonderful career, and I'm extremely proud of all of them. And so my topic today is to present you the trial Ability Diabetes Global. I am the CEO of CIRC, which is the CRO, one of the CRO conducting the trial. I think it's not necessary, especially in India, to say why there is a real rationale to evaluate the treatment of diabetic patients. You are one of the countries with the highest rate. Yes, you are in the countries that have very high rate of diabetics, and it's increasing everywhere. So the rationale, the need for the patient is really there. And as Prof. Colombo was saying, even if since years and years we work hard to improve the treatment of diabetic patients, there is a lot more to do for those patients. So the rationale is the diabetic patients have more events. They have an additional risk of acute and subacute stent thrombosis. They have delayed healing due to slower endothelialization and increased inflammatory response, and this lead also to more stenosis and, as said, more acute thrombosis. So, the objective with this dedicated stent to the diabetic is to compare the abluminous stent to the everolimus, in other terms, the Xience. And we think that at least 40% of patients will be multivessel, because this is the anatomy of diabetic patient. And we thought that we will have at least 30% of acute coronary syndrome. I won't stay long on the device, because you have extensive presentation of it by Prof. Colombo, very well done. Prof. Testa also addressed that. You know that we are with a very special device that has the combination of a last generation DES and a drug eluting balloon that cover the edges also. And so it's really designed to treat a diabetic patient. We hypothesize that this device will provide more drug, greater drug delivery, and also more homogeneous drug delivery per square millimeter and at the vessel wall, and that will reduce the restenosis rate in that population. The study design, you saw it, but I will go a little bit in more detail. So we will recruit 3,000 only diabetic patients eligible for PCI. They will be followed for 2 years. It's prospective, multi-center, multinational, randomized 1-to-1, open label by blinded follow-up. I will go into that later. The primary endpoint is clinically indicated TLR at 1 year. It's powered for non-inferiority, but also sequentially superiority if non-inferiority is met. Is really what we are looking for, a superiority versus Xience. 20 countries, 100 sites, Europe, Asia, Australia, which is part of Asia, South America, and 3,000 patients, I told you, and the two device you saw them. So the diabetic patient will be screened to see if they are eligible for PCI. The doctors will check inclusion-exclusion criteria. Then the patient will go to angiography, because there are angiographic criteria. If they are not validated, it's a screening failure. If they are validated, they go there to randomization, and they will randomize 1 by 1 abluminous Xience. There is a blinded part. The patient, of course, at the moment of PCI, the doctors will know which stent they implanted. But immediately after, meaning at the moment, even at the moment of the report, it's not written anywhere which stent the patient, it's a study device which is written. And the study coordinator performing the follow-up are not the one who enter the procedure data. So since the end of the procedure, everyone will be blinded to the stent as assigned up to the end of follow-up. There is many, let's say, inclusion criteria are very wide, and it's really an all-comer trial, but we want the patient diabetics, but they can be all newly diagnosed diabetic with those criteria, and even only with an HbA1c level over 7%, they can enter in the trial. It can be newly diagnosed, or, of course, patients with the previous documented diabetes, type 1 or 2, and that are treated or oral or by insulin. And any symptomatic coronary artery disease is allowed, except STEMI and cardiogenic shock. For inclusion angiographic criteria, you see that there is really no limitation. They need to have at least one de novo lesion in a native, so grafts are excluded, and in stent restenosis is excluded, but that's all. And then after, there is no limitation of the number of treated lesion, number of vessel, or lesion length. You can treat any patient that has a good indication for treatment. As I told you, we exclude only patients in cardiogenic shock and the STEMI and the severe renal dysfunction for obvious reason of risk of contrast-induced nephropathy. The primary endpoint, as said, TLR, ID TLR at 1 year, powered for inferiority and sequential superiority, and the classical target lesion failure, that is, let's say, the principal R2 criteria. There are many secondary endpoints, but they are also very, very classical. Of course, we follow patient longer. We have several composites, and we will look also to the bark bleeding, of course. Many composites, as I told you, technical success, stent thrombosis, stroke, TVR up to 2 years. That's very classical. How the study is managed? As I told you, Concept Medical is the sponsor. They sponsor the study and they supply the study device. Only, of course, the Abluminous device. The Mount Sinai, and it's a collaboration. I'm very proud of this collaboration. CERC Mount Sinai in the trial organization. Mount Sinai Icahn School of Medicine being responsible of project management, CEC, data management and stats. When CERC will do the site selection, the regulatory submission, the project management, contract also, monitoring, serious adverse event reporting, and the core lab for endpoint related events. There is a wonderful team to execute this trial. Chairperson of the executive team being Roxana Meram, with 3 wonderful study PI, Prof. Colombo, Prof. Abizaid, and Prof. Saito. And the steering committee is the same doctors with Dr. Fadila Malik, Dr. David Ildismis, Darius Dudek, Dr. Tolg, and Dr. Benjamin Faury. So it's a very nice team that we count on to execute well the trial. This is the current status. In green, you see the country where the sites are approved, the regulation process is finished. In yellow, when it's ongoing, meaning submission has been done and we are waiting for answers. And in red, it's when we prepare the package. And we are extremely proud to have 2 sites in India, Dr. Mulasari and Dr. Rajendra Kumar Premchand. And let's say we are looking forward working with them. And before question, to conclude, ladies and gentlemen, extremely happy to be part of this wonderful trial. We can say that the diabetic population is increasing worldwide and continue to have a poor outcome despite all medical improvement, both in, I would say, in drugs and in devices. The Abluminous device, which represents the combination of the best-in-class DES and drug-eluting balloon, with the advantages of both systems, has the potential to address better this population. And the Abluminous Diabetes Global Trial is the largest head-to-head stent trial for diabetics conducted so far. The patient will be recruited in all continents and countries, allowing the conclusion of the trial to be applicable worldwide. Thank you.
Thank you, Dr. Mary Claude, for covering this Abilities Diabetes Global Trial in detail. What we clinicians, what bothers us is, madam, we already have such very low events with existing good generation stents. and to compete with a platform like Zymes and produce the superiority over it is quite difficult. And most of the trials which come with comparative results say that both are equal. So what are your thoughts that this new platform could be proving superior over the existing platform? Now I feel Abbott is sitting pretty. They need not spend any money for any research now. They've done enough. Now all the companies compare their stents with this benchmark stent. But what are your thoughts? You feel that this new trial could prove superiority over the existing Zymes platform?
Yes, of course, as you say, it's not the first time that Xience is challenged, but it has been challenged also with thinner struts, for example, with some mixed results, but some of them were positive. But let's say there we are addressing a population where even all the DS have a worse outcome than the non-diabetic patient. So it's numbers, I agree, are low, but not as low as they could be if the patient were not diabetics. So there is a real gap. And there is no other stents that combine a DES and a DEB. So that's why, of course, with a so big trial, we are looking for non-inferiority. This trial cannot fail for being so too ambitious. But we are all convinced that that there is a good, reasonable chance to get superiority on this trial. Yes.
Thank you, madam. I think we have very two experienced doctors who had a lot of experience with this stent and the regulating balloons platforms which you are using. We have Dr. Rishi and Dr. Ravikant Patil with us. Harshita, can you unmute them so that they can share some experience and clear the doubts with Antonio and Mary Claude? Dr. Rishi is from KGMC Medical College. This is one of the leading centers in the country, do very high volume work. Teaching institutes, we have their trained DM and MD students. Ravikant Patil also has a lot of experience. Both of them are part of this dedicated global registry, and they can share their experience. Can you unmute and show the panelists? I think we have Dr. Sangatuvelu, Dr. Ravikant Patil, Dr. Rishi Sethi, and Sonan Ray as panelists because of their experience. Can we have them unmute?
Yeah. Good afternoon, sir. This is Dr. Ravikant.
Yeah, go ahead, Ravikant.
Yeah. Actually, I just want to share some things like last 2 years, I've been using this stent and I've used more than 3,000 implants in last 2 years. And my personal experience about this is acute stent thrombosis, though I see some in cases, but restenosis, I have not seen, or maybe I've seen very few in with this implant. So I just want to know what is your real life experience about the real world registry about this stent. This is my experience that restenosis rates have come across very less. Acute stent thrombosis, yes, few cases I have come across with this implant.
Dr. Mary Claude or Luca, can you take that?
Oh, yes, I think that Luca can take, Luca and Prof. Colombo can take the question because I have no personal experience in this stent, with this stent.
Well, for sure, I have to say that I started using the Abluminous more than 4 years ago. And well, in large number of patients, because as soon as I started, I targeted diabetic patients with this stent. And I have to say, I have more experience in diabetes rather than in patients without diabetes. However, the thing is that I can remember in 4 years, one event of stent thrombosis in a patient that decided to stop DAPT after a month. Stop. So we had a stent thrombosis, but I think unrelated to the stent, it's just a matter of fact. I mean, if you stop the DAPT much earlier than you should, well, that's a problem. And honestly, I'm not sure we can actually connect the stent with this event. In terms of stenosis, I've seen a few, maybe 5 or 6 in 4 years. So nothing really special. And this is something, to be honest, it is usually I've seen is inside the stent, right in the middle of the stent, where the stent maybe was not truly and properly expanded. So it was possible to recognize a technical issue since the first first implant, which is pretty normal. The very good thing is that I've never seen an edge restenosis, which is something really important, particularly in diabetic patients where the disease is diffuse. I've seen some progression into the artery, but nothing involving the edges of the stent. Of course, I don't have thousands of patients to say that. However, in terms of real-world experience, you know, so far, so good.
Yeah.
Thank you, Dr. Antonio, for joining back. Can you share your comments on this? Did you hear the question?
Yes, thank you. I don't have a large experience. I started using this device only recently, so I cannot discuss the follow-up. The only thing I can say that the durability and the performance of the stent is similar to the most recent new generation DS. So good deliverability, flexibility, and performance. And I'm really happy to hear what Luca Testa said, because I think in Concept Medical, they are investing a lot of money in this study. And I'm sure that they are pretty convinced from preliminary data that there is some clear gain. Again, I'm not convinced that this device will eliminate restenosis or will drastically, but I think it will be a step forward in the right direction. So far, Limus stent, in the way they have been conceived, did not really make an impact in diabetics. And we need a solution, but I doubt any stent will be the solution, but at least a step forward is important.
Thank you, sir. Dr. Sangatwelu,
yeah.
Do you have any questions?
Thank you, and always nice to see Dr. Mary Claude. Thank you very much, and nice, interesting presentation. So, are there any concerns of increased dose of sirolimus? I know the preliminary registries have shown nice results, but do you consider that in terms of dosing?
I think that it's not only dosing. I don't think that there is more than on a regular stent. It's just that it's completely homogeneous. Usually, the sirolimus is on the strut of the stent and then diffuse. There, it's a layer. It's a thin layer. So completely and elastic, meaning that when you deploy, which is over the stent and over the balloon, meaning that when you deploy your balloon, you expose the whole surface to this layer of sirolimus, including the edges. And we know that 20% of the in-stent restenosis are edges restenosis.
Okay, I think we had a very good discussion, a lot of interesting things coming up, where Indian company is coming up with a good technology of Limus balloon and then probably newer versions of stents. We wish they could work very well in this diabetic subgroup of patients. And Colombo proposed some newer concepts of DEB usage as well as this combination of this could do well. And any final question from Dr. Rishi? Are you there?
Yeah, hi. Sorry,
yeah,
there was an interruption. There was an interruption in my internet connection. As you already told, we have a little experience with the use of this device in our hospital, and we are also a part of the DIABETIC registry. I just want to ask Luca or Madam, maybe. I mean, what is it in diabetes that? What do you think is the key factor with this device in the diabetes? Are we relying too much on the earlier data of the registry, the enabled registry, to go after diabetes all along? Or are we convinced that in this device there's something, is it the drug-eluting balloon, or is it the dosage? What exactly is the key component as a pathophysiological basis that we believe will be so effective in diabetics, as we are putting all our eggs into one basket and we're not going for any complex coronary lesions and just targeting diabetes for all our clinical studies and registries in future? What do you think is your take on what Luca, if you can answer that. Maybe
Well, actually, I was, thanks for the question, by the way. I mean, that's exactly the point. So I believe, and we believe, that the fact that this is a unique fusion between a DB and a DES with abluminal coating. By the way, this coating is also bioresorbable. So it's not something staying there, well, actually fueling inflammation. So there are some technical features. The first one, at least in my mind, is the fact that we are releasing an homogeneous dose of sirolimus. And this is crucial. Plus, there is also a coating at the edges, which is absolutely new thing as compared to any other available drug eluting stent. Number three, there is actually a burst of drug during the implantation, and that's the reason why you have to keep the balloon inflated for 40-45 seconds. And then there is also a controlled release over 1 month. Plus all these features together, I believe they will be able to, to make a step ahead. We need to remember that diabetes is a metabolic disease. So what we are looking at is a way to face the hurdles of PCIs. But clearly, if there, for example, there's no glycemic control, if there's no drug medications, if there's nothing, besides PCI, that would be useless. What we are looking at is a way to address the ischemic heart disease in diabetic patients. However, there's a conundrum. A diabetic patient is a whole world that needs to be addressed. But definitely, we are starting from something that in terms of techniques is something new and very promising. We'll see.
Thank you. We had an excellent discussion. I think we need to move on. Thank you, Dr. Mary Claude, Dr. Antonio Colombo, and Dr. Luca for participating in this. My wish to have Dr. Colombo to inaugurate this TCT has come true. Maybe thanks to COVID pandemic, we could have time and all the interesting sessions we had and will continue to have. And we thank all these session chairpersons and speakers. And we'll move on to the next session that is basically on endovascular procedures and peripheral arterial disease. We wish all of you to continue. And if you're interested, then we'll have interesting discussions on drug-eluting balloon usage also in the peripheral vascular disease. My good friend, Dr. Rajendra Kumar Jain, who is the Director of Cardiology and owner of the KIMS Krishna Institute of Medical Sciences, Hyderabad, and Dr. N.N. Khanna, Senior Consultant Cardiologist in Apollo Hospital, Delhi, and very senior cardiologist and well-wisher, Dr. Manutosh Panja, sir, from Kolkata, will chair this endovascular and peripheral interventions. As you know, Dr. Manutosh Panja is also known for his work in the Thalassemia, arthritis and other fields. We have other panelists joining. I think we have Dr. Samir, Manoj, Neeraj, and many others. I request all of them to come over and take over the session. Jane on the...
Dr.